Up next, we have the effects of plavix duration on carotid artery in-stent restenosis, Dr. Jokish from University of South Florida, Tampa.
Hi, my name is Chrissy Jokish. I'm one of the vascular surgery integrated residents at the University of South Florida. Thank you for the opportunity to present. I have no disclosures. Since the approval of transcarotid artery revascularization, or TCAR, by the FDA in 2015, there's been a noted increase in the use of carotid artery stenting. Carotid endarterectomy appears to remain the dominant operative treatment modality for carotid disease. However, the proportional use of endarterectomy continues to decrease annually, while the use of carotid stenting is on the rise. Surveillance after treatment remains an important tool in evaluating for restenosis. Data suggests that patients who experience restenosis within the first 2 years of their intervention are at greater risk of ipsilateral stroke than those who do not experience restenosis. Additionally, several studies show a higher rate of restenosis noted after carotid stenting when compared to carotid endarterectomy. Restenosis occurring within 2 to 3 years after surgical intervention is commonly attributed to neointimal hyperplasia, which is characterized by an endothelial injury initiating the proliferation and migration of smooth muscle cells within the intima and ultimately lumen narrowing. This is typically thought to be associated with a lower risk of thromboembolic events when compared to primary atherosclerotic disease. However, there is data to suggest a higher rate of ipsilateral stroke associated with restenosis during the first 2 to 3 years, implying that neointimal hyperplasia may carry a higher risk of stroke than previously thought. It has been proposed in animal studies that plavix may play a role in the mitigation of intimal hyperplasia due to its anti-inflammatory properties. Several studies have also shown that the use of dual antiplatelet therapy reduces the risk of acute stent thrombosis in the immediate postoperative period. Current guidelines recommend dual antiplatelet therapy starting 3 days prior and continuing for at least 30 days after carotid stenting. There is limited real-world data available concerning the duration of dual antiplatelet therapy in this stenting population, and much of our clinical evidence is derived from coronary studies. So the objective of our study was to evaluate the effect of the duration of dual antiplatelet therapy on carotid in-stent restenosis. This was a single-center retrospective review conducted out of the Veterans Affairs Hospital over a 20-year period. Patients were divided into short-term and long-term plavix users based on their postoperative therapy duration of less than or greater than 6 weeks, respectively. In-stent restenosis was defined as a peak systolic velocity of greater than 224 in symptomatic patients, which was indicative of greater than 50% restenosis, or peak systolic velocity of greater than 325 centimeters per second in asymptomatic patients, representing greater than 80% restenosis. This was based on previously published velocity criteria. Our primary outcome was in-stent restenosis at 1 year, 2 year, and 5 year intervals. We also evaluated perioperative, or within 30 days, and postoperative greater than 30 days stroke, or TIA, postoperative bleeding events, and death as our secondary outcomes. There was a total of 278 stenting procedures performed in 254 patients included in our study. Of these patients, 159, or roughly 57%, were on plavix for less than 6 weeks, and 119, or 43%, were considered long-term plavix users. Demographic information was largely similar between the two groups. Short-term plavix users were more likely to have a history of atrial fibrillation and were less likely to have a history of CABG, diabetes, or coronary artery disease. Overall, there were a total of 19 occurrences of in-stent restenosis that occurred during our study period. Across all timeframes, the duration of plavix therapy on in-stent restenosis was not noted to be statistically significant. While not statistically significant, it should be noted that of the 13 patients who experienced in-stent restenosis at 1 year, the overwhelming majority of 77% were noted to be on short-term plavix therapy. This trend was not noted during the other studied timeframes. The majority of patients who developed in-stent restenosis were broken down by demographics and were noted to be on long-term plavix therapy, with 86% of diabetic patients and 71% of patients with coronary artery disease or prior TIA. Despite this trend, patient demographics with respect to plavix duration overall was not statistically significant. With respect to our secondary outcomes, the duration of plavix therapy also did not play a role in perioperative or postoperative cerebrovascular events. Similarly, no difference in perioperative bleeding events were noted. There were no deaths observed in our study. So in conclusion, the rates of in-stent restenosis were similar for both groups, regardless of plavix duration. No significant difference was noted in perioperative or postoperative cerebrovascular events or bleeding. Based on these results, it is reasonable to consider a shorter duration of plavix therapy after carotid artery stenting in patients with no other indication for dual antiplatelet therapy. Thank you.
Good morning.
Morning.
Misty Humphreys from UC Davis. This is a single institution study, so you have the ability to look at anatomic issues and the nature of the anatomy through imaging. So can you tell me if there were any differences in the anatomic issues? Maybe there was carotid disease, common carotid disease that wasn't treated. Maybe there were 2 stents that were put in, so there was a long stent with overlapping. Can you tell me a little bit about those things?
Sure. We did have, there were a few patients in our study that did have common carotid artery disease rather than internal carotid artery. As far as 2 stents overlapping, we did not observe that in our study period, actually. It was mainly just 1 stent. The 2 stents used in our study were exact stents, Abbott Exact for transfemoral, and then the Silk Road en route with respect to TCAR.
Dr. Conrad.
Yeah, Mark Conrad from Boston. You know, the big thing with stenting now is talking about plavix non-responders, right? And so somewhere between 5 and 10% of patients are going to fall into that route. Now, clearly the patients from 1996, we didn't even know that was a thing.
Sure.
But were you able to, one, did you test for the response to plavix in all the patients? And if you started doing that, were you able to divide the patients into when you tested so you know that they respond or when they didn't to see if there was a difference?
Unfortunately, we are not testing for that at the VA hospital right now. We've tried in the past, and it's been kind of difficult. So at the Veterans Affairs Hospital, we're not able to do that easily.
Great presentation, Dr. Jokic. Adding on to the clopidogrel conversation, did you look at what percentage of patients were on maximal or optimal medical therapy? And then the second question is how that optimal medical therapy has changed over the last 20 years. If in the last 10 years you have a reduction in restenosis rate.
Sure. So that's a really good question, actually. So we did look at the best medical therapy and whether or not patients were on statin therapy and whether diabetes was controlled. Luckily, in the veterans population, that stuff is really well monitored, and most patients were on best medical therapy. As far as looking in the last 10 years to see if the changes in medications made a difference in in-stent restenosis, unfortunately, I didn't look at that, but that'd be something interesting to look at for the manuscript.
Thank you.
Thank you.